And we are back. We are going to be continuing on to chapter 39 here, which will get me through. Let's take a peek here. It says here I need to read portions of this 3990 to 4048. So let's see what 3090. We're starting at the urinary tract infection. So urinary tract infection is urinary tract infection 1254. So we're going from 1254 to 4048. 4048 looks like end-stage kidney disease. That's very ending. So the end of the chapter. So we'll jump right into urinary tract infections. Our urinary tract infection. So what are the causes? Causes of urinary tract infection is an inflammation of urinary epithelium, usually caused by bacteria from gut. A UTI can occur anywhere along the urinary tract, including the urethra, bladder, ureter, or kidney. At risk of premature newborns, pre-puberty children, sexually active and pregnant women. Women treated with antibiotics that disrupt vaginal flora, spermicide users, estrogen deficient postmenopausal women, individuals with indwelling catheters, and a person with diabetes, neurogenic bladders, or urinary tract obstruction. So pretty much just about anybody can be at risk for a UTI. Cystitis is more common in women because of the shorter urethra and the closeness of the urethra to the anus, increasing the possibility of bacterial contamination. Up to 50% of women may have a lower UTI at some time in their life. Uncomplicated UTIs are generally mild and without complications, and they occur in individuals with a normal urinary tract. A complicated or febrile UTI develops when there is an abnormality in the urinary system or a health problem that compromises host defense, such as HIV, renal transplant, diabetes, or spinal cord injury. UTI may occur alone or in association with pyelonephritis, prostatitis, or kidney stones. Kidney stones. Up to 40% of cases of septic shock are caused by urosepsis that present in the emergency room. Recurrent UTI is commonly defined as 3 or more UTIs within 12 months, and 2 or more occurrences within 6 months. It may occur as a relapse when there is a second UTI caused by the same pathogen within 2 weeks of the original treatment, or a reinfection that occurs more than 2 weeks after completion of treatment for the same or different pathogen. Mechanisms of UTI are described in figure 36 or 39.6. So, bacterial factors and host factors. Your mechanisms of a UTI. You have your capsular antigen resistant phagocytosis. You have your hemolysin damaging the epithelium. You have urease, positive bacteria promotes infection. You have your adhesins, your E. coli type 1 and P. Fimbriae bind to uroepithelium. You have kidney stones, diabetes, immunosuppression, ureteral reflux, your pregnancy neurogenic bladder, your P blood group antigens, your prostatic hypertrophy, short urethra in women, and indwelling catheters, and finally that E. coli contamination from the colon. That's why hospitals are heavy against CLABSIs. Make sure you take out those urinary catheters quickly. Your host defense mechanism and urinary tract infection. That host defense mechanism maintains a sterile posterior urethra and bladder in a healthy individual. Even if bacteria manage to enter the bladder, the defense mechanisms prevent it from clinging to the bladder of the bladder. Wait, what? Even if bacteria manages to enter the bladder, these defense mechanisms prevent it from clinging to the walls of the bladder or ascending to the upper urinary tract. Several factors normally combine to protect against UTIs. Most bacteria are washed out of the urethra during micturition. The low pH and high osmolality of urea, the presence of uromodulin, and secretion from the uroepithelium provide a bactericidal effect. The ureterovesical junction closes during bladder contraction, preventing reflux of urine to the ureters and the kidneys. Your periurethral mucus-secreting glands surround the distal two-thirds of the female urethra. Mucus from these glands traps bacteria before it can ascend from the proximal urethra to the bladder. In men, the length of the male urethra and secretions from the prostate and accessory periurethral glands combine to form a protective barrier against infection. In addition, the urethral sphincter mechanism acts as a mechanical barrier to bacterial ascent from the distal urethra. Bacteria that successfully ascend the urethra face detection and destruction by components of the body's immune system, provided they come into contact with the bladder wall. Protective uroepithelial immune response include toll-like receptors, your TLR4s, recognition of pathogen-associated molecular patterns on the bacteria, your neutrophils and macrophage recruitment, and your phagocytosis. Susceptibility to infection also is influenced by genetic variation in the host immune response to bacterial virulence and by the virulence of the pathogen. So, unfortunately, time is required for the immune system to respond to the potential threat, and this period may provide adequate time for bacteria or other pathogens to reproduce several times. The efficiency of bladder's defenses is also influenced by the person's Lewis blood group. This taxonomy is based on recognition of inherited antigens associated with ABH blood factors. Individuals with certain Lewis blood groups are more prone to UTIs because they secrete fewer antigens capable of resisting bacterial adherence by pilus formation. Most people are capable and are able to rapidly rid the urinary tract of invading bacteria, but some show evidence of bacteria in the urine that does not provoke an infection. This condition, called asymptomatic bacteriuria, does not harm urinary function or require intervention except in pregnant women or individuals experiencing urinary tract surgery. A UTI occurs when a pathogen circumvents or overwhelms the host's defense mechanism and rapidly reproduces. So there's types of urinary tract infection. There's that acute cystitis. The acute cystitis is an inflammation of the bladder and the most common site of UTI. The morphologic appearance of the bladder through a cystoscopy describes different types of cystitis. With mild inflammation, the mucosa is hyperemic or red. More advanced cases may show diffuse hemorrhage, termed hemorrhagic cystitis, pus formation, or suppurative exudate, termed suppurative cystitis, on the epithelial surface of the bladder. Prolonged infection may lead to sloughing of the bladder mucosa with ulcer formation, termed ulcerative cystitis. The most severe infections may cause necrosis of the bladder wall, termed gangrenous cystitis. None of it sounds pleasant. Pathophysiology. Two factors account for the presence of a UTI: the efficiency of defense mechanisms within the host, the individual, and the virulence of the pathogen, the bacteria, fungus, or parasite. The most common infecting microorganism are uropathic strains of E. coli, about 80% to 85%, and the second most common is a Streptococcus saprophyticus, about 10%. Less common microorganisms include Klebsiella, Proteus, Pseudomonas, fungi, viral, parasites, and tubercular bacilli. Schistosoma hematobium is the most common cause of a parasitic invasion of the urinary tract. On a global basis, it infects more than 200 million people and has a strong association with bladder cancer. Bacterial contamination of the normal sterile urine usually occurs by retrograde movement of uropathic gram-negative bacilli, usually again that E. coli, from the gut into the urethra and bladder, and then to the ureter and kidneys. Strains of E. coli also produce cytorophores for acquiring nutrient iron, are resistant to bactericidal agents of complement, and express toxins including cytotoxin, necrotizing factor 1, and hemolysin. Certain bacterial species also enhance their virulence by acting together to form a biofilm that enhances colonization and resists efficiency of innate host defense mechanisms and antimicrobial therapy. Particularly in catheter-associated UTIs, uropathic strains of E. coli have a type 1 fimbriae that binds to latex catheters and receptors on the uroepithelium. They resist flushing during normal micturition and have flagella that propel them upstream. These strains also have P. fimbriae, or pyelonephritis-associated fimbriae, that bind to the uroepithelium and individuals with P blood group antigen and flagella that propel them upstream. Some women may be genetically susceptible to certain strains of E. coli attachment and may harbor pathogenic strains in their vaginal flora. Fungal infections are comparatively uncommon. The most common pathogen is Candida, but multiple fungal species may colonize the urinary tract or urinary catheters and produce symptomatic UTIs, particularly in those who are immunosuppressed. Hematogenous infections are uncommon and often preceded by septicemia. Infection initiates an inflammatory response and the symptoms of cystitis. So what kind of clinical manifestations would we see? Well, clinical manifestations of cystitis are related to the host's inflammatory response and usually include frequency, urgency, and dysuria, that painful urination, and suprapubic and lower back pain. The inflammatory edema in the bladder wall stimulates discharge of stretch receptors, initiating symptoms of bladder fullness with small volumes of urine, and producing the urgency and frequency of urination associated with cystitis. Hematuria, cloudy and foul-smelling urine, and flank pain are more serious symptoms. Approximately 10% of individuals with bacteriuria have no symptoms, and 30% of individuals with symptoms are abacteriuric. Older adults with cystitis may be asymptomatic or demonstrate confusion or vague abdominal discomfort. Older adults with recurrent UTI and other concurrent illness have a higher risk of morbidity and mortality. So, what is our evaluation and treatment? Infections in symptomatic individuals are diagnosed by urine culture of specific microorganisms with counts of 10,000 ml or more from freshly voided urine. Urine dipstick that is positive for leukocyte esterase or nitrate reductase can be used for diagnosis of an uncomplicated UTI. Risk factors such as a urinary tract obstruction should be identified and treated. Evidence of bacteria from urine culture and antibiotic sensitivity warrants treatment with a microorganism-specific antibiotic. Acute uncomplicated cystitis in non-pregnant women can be diagnosed without an office visit or a urine culture. If a urine culture and sensitivity are ordered, the urine specimen must be obtained before the initiation of any kind of antibiotic therapy. 3 to 5 days of treatment is most common. Complicated UTI requires 7 to 14 days of treatment. From 20 to 25% of women have relapsing infection within 7 to 10 days, requiring prolonged antibiotic treatment. Follow-up urine cultures should be obtained 1 week after initiating or the initiation of treatment and at monthly intervals for 3 months. Clinical symptoms are frequently relieved, but bacteria urea may still be present. Repeat cultures should be obtained every 3 to 4 months for about 1 year after treatment for evaluation and treatment of recurrent infection. Recurrent UTI is effectively treated with short courses of antibiotics, but antibiotic resistance is an emerging problem. Urosepsis and septic shock are medical emergencies that usually demand parenteral broad-spectrum antibiotic therapy and may require hospitalization. A UTI caused by a schistosomiasis is treated with presenquitol. Non-infectious cystitis is associated with radiation or chemotherapy treatment for pelvic or urogenital cancers and is treated symptomatically. Interstitial cystitis, or the painful bladder syndrome. The interstitial cystitis, painful bladder syndrome, IC or PBS, is defined as an unpleasant sensation. Well, as the name says, painful bladder syndrome has pain, pressure, discomfort, perceived to be related to the urinary bladder, associated with lower urinary tract symptoms of more than 6 weeks duration in the absence of infection or other identifiable causes. It occurs most commonly again in women ages 20 to 40 years of age. Some individuals also experience fibromyalgia, irritable bowel syndrome, chronic fatigue syndrome, Sjögren's syndrome, chronic headaches, and vulvodynia. The cause of IC-PBS is unknown, but an autoimmune reaction may be responsible for the inflammatory response, which includes mast cell activation, altered epithelial permeability, neuroinflammation, and increased sensory nerve sensitivity. The inflammation is associated with a derangement of the glycosaminoglycan layer of the bladder mucosa that makes it more susceptible to penetration by bacteria and noxious urinary solutes. Inflammation and fibrosis of the bladder wall are accompanied by the presence of hemorrhagic ulcers, your Hunter ulcers, in some individuals, and bladder volume may decrease as a result of fibrosis, particularly in older individuals. Antiproliferative factor, APF, a protein expressed by the bladder uroepithelium in those with IC, may be a biomarker. APF, again that antiproliferative factor, appears to block the normal growth of cells that line the inside wall of the bladder and indirectly increase bladder sensation, which would make sense. APF, antiproliferative, would then block normal cell growth because proliferation is growth of cells. Your characteristic symptoms of IC include bladder fullness, frequency, including nocturia, small urine volume, and chronic pelvic pain, with symptoms lasting longer than 6 months. Chronic pain and sleep deprivation can lead to depression. Your diagnosis of IC requires a thorough history, physical exam, and urinalysis, analysis of cystoscopic findings, and the exclusion of other diagnoses. No single treatment is effective. Oral and intravesical therapies, sacral nerve stimulation, and the Botox, Aonabotulinum toxin A, are used for symptom relief. Surgery is used in refractory cases. More research, though, is needed to understand the pathogenesis and long-term treatment plan of this disease. Your acute polynephritis. Polynephritis is the infection of one or both of the upper urinary tracts. So that would be your ureters, your renal pelvis, and your kidney interstitium. Common causes are summarized here on this table in 39.4. Your urinary obstruction and reflux of urine from the bladder, your vesicoureteral reflux, are the most common underlying risk factors. Again, most cases occur in women. So we got kidney stones, your vesicoureteral reflux, pregnancy, neurogenic bladders, instrumentation, and female sexual trauma. Your pathophysiology includes the following. Your microorganisms usually associated with acute pyelonephritis include E. coli, Proteus, and Pseudomonas. The latter two microorganisms are more commonly associated with infections after urethral instrumentation or urinary tract surgery. These microorganisms also split urea into ammonia, making alkaline urine that increases the risk of stone formation. The infection is probably spread by ascending uropathic microorganisms along the ureters. Dissemination also may occur by way of the bloodstream, and both kidneys are usually involved. The inflammatory process is usually focal and irregular, primarily affecting the pelvis, calyces, and medulla. The infection causes medullary infiltration of neutrophils, and with the tubulointerstitial inflammation, renal edema, and purulent urine. In severe infection, localized abscesses may form in the medulla and extend to the cortex. Your primary affected are the renal tubules. The glomeruli usually are spared. Necrosis of renal papillary can develop. After the acute phase, healing occurs with deposition of scarred tissue, fibrosis, and atrophy of the affected tubules. So acute polynephritis rarely causes renal failure. However, looking at polynephritis, on the right, a small, shrunken, irregularly scarred kidney of the individual with a chronic polynephritis. The left kidney is a normal size, but also shows scarring on the upper pole. So what are clinical manifestations? Well, the onset of symptoms is usually acute with fever, chills, and flank or groin pain, symptoms characteristic of a UTI, including frequency, dysuria, and costovertebral tenderness, may supersede systemic signs and symptoms. Older adults may have non-specific symptoms, such as a low-grade fever and malaise. So your evaluation and treatment. Differentiating symptoms of cystitis from those of polynephritis by clinical assessment alone can be difficult. The specific diagnosis is established by a urine culture, urinalysis, and clinical signs and symptoms. White blood cell casts indicate polynephritis, but they are not always present in the urine. Complicated polynephritis requires blood cultures and urinary tract imaging. Uncomplicated acute polynephritis responds well to 2 to 3 weeks of microorganism-specific antibiotic therapy. Follow-up urine cultures are obtained at 1 and 4 weeks after treatment if symptoms occur. Antibiotic-resistant microorganisms or reinfection may occur in cases of urinary tract obstruction or reflux. IV pyelograph and voiding cystourethropy identify surgically correctable lesions. So chronic polynephritis is a persistent or recurrent infection of the kidney leading to scarring of the kidney. One or both kidneys may be involved, and The specific cause of the chronic pyelonephritis may be unknown, idiopathic, or associated with chronic UTIs, vesicoureteral reflux, renal stones, or obstructive uropathy. Recurrent infections from acute pyelonephritis may be associated with chronic pyelonephritis. Causes other than chronic pyelonephritis include drug toxicity from analgesics, such as nonsteroidal anti-inflammatory drugs, ischemia, irradiation, and immune complex disease. So what is our pathophysiology? Chronic urinary tract obstruction prevents elimination of bacteria and starts a process of progressive inflammation, alterations of the renal pelvis, and calluses, destruction of the tubules, atrophy or dilation, and diffuse scarring, and finally impaired urine concentrating ability, leading to chronic kidney failure. The lesions of chronic pyelonephritis are sometimes termed chronic interstitial nephritis because the inflammation and fibrosis are located in the interstitial spaces between the tubules. Clinical manifestations include the early symptoms of chronic pyelonephritis are often minimal and commonly include frequency, dysuria, and flank pain, and may include hypertension. Progression of the disease may lead to renal failure, particularly in the presence of other risk factors, obstructive uropathy, or diabetes mellitus. There is an inability to observe sodium with loss of tubular function and the development of hyperkalemia and metabolic acidosis. Your risk for dehydration must be considered if there is a loss of the ability to concentrate the urine. Your evaluation and treatment. Urinalysis and IV pylography and ultrasound are used diagnostically. Treatment is related to the underlying cause. If there is obstruction, it must be relieved. Antibiotics may be given with prolonged antibiotic therapy for recurrent infections. So that leads us to our glomerular disorders. So your acute glomerulonephritis. That is an inflammation of the glomerulus caused by primary glomerular injury. That could include immunologic responses, ischemia, free radicals, drugs, toxins, vascular disorders, but also infection. Your secondary glomerular injury is a consequence of systemic disease, such as diabetes, systemic lupus, erythematosus, and the less commonly congestive heart failure and HIV-related kidney disease. Glomerular disease is a significant cause of chronic kidney disease and end-stage renal failure worldwide. So, what is the pathophysiology? Well, your immune mechanisms are a major cause of injury for primary and secondary causes of glomerular nephritis. The injury damages the glomerular capillary filtration membrane, including the endothelium, basement membrane, and epithelium, your podocytes. The most common types of immune injury include the deposition of circulating antigen-antibody immune complexes into the glomerulus, your type 3 hypersensitivity. Reaction of antibodies in situ against planted antigens within the glomerulus, your type 2 hypersensitivity, your cytotoxicity. And action of antibodies directed against glomerular capillary wall, your anti-glomerular basement membrane antibodies. The least common and most severe form of immune injury is a type 2 hypersensitivity and a cell-mediated immune injury, a type 4 hypersensitivity. Non-immune glomerular injury is related to ischemia, metabolic disorders, your diabetes, your toxin exposures, drugs, vascular disorders such as vasculitis, and infection with direct injury to glomerular cells. Different causes of injury may result in more than one type of glomerular lesion. Thus, lesions are not necessarily the disease specific. So, then we are taking a look at the mechanisms of glomerular injury. Your AB is your antibody, your GBM is your glomerular basement membrane, your GFR, that filtration rate, and NO, your nitric oxide. And here is a table of immunologic pathogenesis of glomerular nephritis. So, depending on the glomerular injury, there could be a soluble immune complex glomerulonephritis that 90% of the time happens. Your anti-glomerular basement membrane glomerulonephritis, about 5%. Your alternative complement pathway and cell-mediated immunity. So, the last 5%. And here we have a table or classification of glomerular lesions and different types. Your diffuse, your focal, your global, your segmental local, your mesangial, your membranous, proliferative, sclerotic, crescentic, and interstitial fibrosis. So, all different types of lesions also could be a causative factor. Your immune injury is caused by activation of biochemicals, mediators of inflammation, complement and cytokines from leukocytes, and begins after the antigen-antibody complexes have deposited or formed in the glomerular capillary wall, or mesangium. Complement can't be deposited with the antibodies, and activation can cause cell lysis, or severe as a chemotactic stimulus for attraction of neutrophils, monocytes, and T lymphocytes. These phagocytes, along with activated platelets, further the inflammatory reaction by releasing mediators that injure the glomerular filtration membrane, including epithelial cells, glomerular basement membrane, and endothelial cells, your podocytes, and filtration slits. The injury increases glomerular membrane permeability and reduces glomerular membrane surface area. There also may be swelling and proliferation of mesangial cells and expansion of the extracellular matrix in the Bowman space, contributing to the crescent formation. The result is decreased glomerular blood flow, hypoxic injury, decreased driving hydrostatic pressure, decreased GFR, and increased serum creatinine levels. So here you have the comparison between a normal glomerulus and the diabetic glomerulopathy. So if you take a look at the endothelial cell, you then see the arterial hyalinosis. Then the basement membrane is thickened. Your parietal cell looks about the same, but that mesangial cell now shows hypertrophy. Your albumin looks unchanged, but if you take a look at that mesangial cell, you now have a collagen deposition. Your glomerular capillary also looks about the same, and the podocyte foot process is not thickened normally. Whereas if you look on the left, you see the collagen deposition, your podocyte loss via your hypertrophy, the podocyte foot process effacement, then it looks like you're getting the collection of albumin, urea, so loss of albumin in the urine. Your tubule epithelial cells also now no longer have that nice fine phala. The tubular epithelial atrophy, the activated myofibroblasts and matrix, An influx of inflammatory cells decrease the number of capillaries. So you see quite the difference between a diabetic and a normal glomerulus. The loss of negative electrical charge across the glomerular filtration membrane and the increase in filtration pore size enhance movement of proteins into the urine. Proteins are normally repelled because they also have a negative charge. Red blood cells also escape if pore size is large enough. Proteinuria and hematuria, or both, may develop. The severity of the glomerular damage and the decline in glomerular function is related to the size, number, and location, whether it's vocal or diffuse, of cells or the cellular injury, the duration of exposure, and the type of antigen-antibody complex. The mechanisms of acute glomerulonephritis are presented next, along with membranous glomerulonephritis, crescentic or rapidly progressive glomerulonephritis, mesangial proliferative glomerulonephritis, and membranous proliferative glomerulonephritis. Immunoglobulin A, or IgA, nephropathy is the binding of abnormal IgA to mesangial cells in the glomerulus, resulting in injury and mesangial proliferation, and presented in Chapter 40. So, features of these types of glomerulonephritis are summarized here on this table. So, I'll leave that table up for a moment. So, the type and cause versus the histopathophysiology. So, I'll click slowly down through this so we can take a look at it together. So your glomerular basement membrane is your GBM, your GFR, your HIV, IgA immunoglobulin A, IgG immunoglobulin G, SLE, your systemic lupus erythematosus. That leads us to our focal segmental glomulosclerosis, which is a scarring lesion that involves some but not all the glomerular, if it's focal, and some but not all if it's the glomerular capillaries, segmental. The disease is characterized by primary podocyte injury related to gene alterations in podocyte structure, familial form, or a lesion that occurs secondarily in any type of chronic kidney disease, such as HIV or drug use. There are increases in mesangial matrix, a loss of endothelial cells, and obliterations of capillary lumens by sclerosis and podocyte derangement. It is the most common cause of nephrotic syndrome in adults, compared to minimally changed disease in children. Your membranous Your membranous nephropathy, also known as membranous glomerulonephritis, is one of the most common causes of acute glomerulonephritis. It affects middle-aged or older adults and is more common in men than women, usually a 2-to-1 ratio. Primarily, membranous nephropathy is caused by subepithelial deposition of circulating antibodies or antibodies formed in situ to antigens located on glomerular podocytes. Assays are available to detect this antigen. The antigen-antibody complexes activate the C5b C9 fragments of the complex, the membrane attack complex, with injury and release of inflammatory mediators by mesangial and epithelial cells, resulting in increased membrane permeability thickening of the glomerular membrane, and ultimately glomerular sclerosis. Your secondary membranous nephropathy is associated with various disorders, including infections such as your hepatitis B and C, systemic lupus, erythematosus, some drugs such as your penicillamine, and also could be caused by cancers. Your proteinuria and nephrotic syndrome are the most common manifestations with risk for thromboembolisms. Alkylating agents plus corticosteroids or calcineurin inhibitors are used for treatment. You could rapidly progressive crescentic glomerulonephritis, also known as subacute or extracapillary glomerulonephritis, is a rare disease and develops over days to weeks. This disease affects primarily adults, usually in their 50s to 60s, and may be an idiopathic or associated with a proliferative glomerular disease, diffuse proliferation of extracapillary cells, such as lupus or post-streptococcal glomerulonephritis. Antiglomerular basement membrane antibodies and anti-neutrophil cytoplasmic autoantibody, ANCA-associated vasculitis, are associated with glomerular injury and may be associated with pulmonary hemorrhage, your Goodpasture syndrome. There is accumulation of T cells and macrophages with extensive proliferation of glomerular epithelial cells, again into the Bowman space. The accumulation of cells promotes the crescent formation, the shape of the Bowman capsule. Heparin-binding epidermal growth factor-like growth factor, your HBEGF, released from glomerular epithelial cells is associated with the proliferation. Typically, the glomerular injury is accompanied by a rapid decline in glomerular function, progressing to renal failure in a few weeks or months. Hematuria, nephritic syndrome, is common and may or may not be accompanied by proteinuria, edema, or hypertension, that nephrotic syndrome. There are three types of RPGN distinguished by immunofluorescent and electron microscopic study of the renal biopsy. Types of RPGN are summarized in Table 39.7. RPGN has a relatively poor prognosis if not diagnosed and treated early. Anticoagulants may be of some benefit in reducing the fibrin component of the crescent formation. Plasmapheresis is usually combined with corticosteroids and immunosuppression therapy. Dialysis or transplantation is required when failure is irreversible. Your mesangial proliferative glomerulonephritis is usually idiopathic and involves the deposits of immune complex into the mesangium with mesangial cell proliferation. It can be associated with an IgA nephropathy, lupus nephritis, or early diabetic nephropathy. Mesangial expansion reduces blood flow and alters filtration membrane permeability with development of hematuria, proteinuria, hypertension, and uremia, that nephrotic syndrome. Membranoproliferative glomerulonephritis is an idiopathic pattern of glomerular injury that involves proliferation of mesangial cells and formation of crescents related to the deposition of complement, that C3 component, and inflammatory injury. This disease is rare and can be associated with autoimmune diseases, infections such as hepatitis B and C, and monoclonal gammopathy. Hypocomplementemia is associated with all types of MPGN, and they are differentiated by light microscopy. All three types stain positive for complement component C3 and are summarized in Table 39.7. Injury to the glomerular capillary wall and all types of MPGN can cause proteinuria, hematuria, nephrotic syndrome, and acute or chronic kidney failure. Clinical manifestations. The onset of glomerular disease may be sudden or insidious, and significant loss of nephron function can occur before symptoms develop. Acute glomerulonephritis may be silent, moderate, mild, moderate, or severe. And symptom presentation. There are no specific clinical signs. Severe or progressive glomerular disease causes oliguria, urine output less than 30 ml per hour, hypertension, and renal failure. Vocal lesions tend to produce less severe clinical symptoms. Salt and water are reabsorbed, contributing to fluid volume expansion, edema, weight gain, and hypertension. Two major symptoms of more severe glomerulonephritis are proteinuria exceeding 3 grams per day to 5 grams per day with albumin as the major protein, and hematuria with red blood cell casts. Nephrotic syndrome is associated with gross proteinuria and lipid sediment. Nephritic syndrome is associated with red blood cells escaping through the glomerular membrane, producing a smoky, brown-tinged urine, red blood cell casts, and accompanying proteinuria. Glomerular bleeding provides prolonged contact with the acidic urine and transforms hemoglobin to methemoglobin, which has a brownish color and no blood clots. In comparison, bleeding from sites lower in the urinary tract produces a pink or red-colored urine. The urine sediment of chronic glomerular disease has waxy casts, granular casts, and less protein and blood than found in nephrotic or nephritic syndromes. Evaluating and treatment. The diagnosis of glomerular disease is confirmed by progressive development of clinical manifestations and laboratory findings of abnormal urinalysis, with proteinuria, red blood cells, white blood cells, and casts. Reduced GFR during glomerulonephritis is evidenced by elevated plasma urea, cystatic C, and creatinine concentrations, or reduced renal creatinine clearance. A renal biopsy provides a specific determination of renal injury and type of pathologic condition. Patterns of antigen-antibody complex deposition or formation within the glomerular capillary filtration membrane have been established using light electron and immunofluorescent microscopy. Electron microscope differentiates morphologic changes within the glomerular capillary wall. Staining with fluorescein identifies complement and different antibodies, your IgG or IgA, and their configurations when viewed under ultraviolet light with light microscopy. Management principles for treating glomerulonephritis are related to treating the primary cause, preventing or minimizing immune response, and correcting accompanying problems, such as edema and hypertension. Specific treatment regimens are necessary for particular types of glomerulonephritis. Antibiotic treatment is essential for the management of the underlying infection that may be contributing to ongoing antigen-antibody response. Corticosteroids decrease antibody synthesis and suppress inflammatory responses. Cytotoxic agents, your cyclophosphamide, may be used to suppress the immune response in corticosteroid-resistant cases. Anticoagulants may be useful for controlling fibrin crescent formation in rapidly progressive glomerulonephritis. So that leads us to the chronic condition of glomerulonephritis. Chronic glomerulonephritis encompasses glomerular disease with a progressive course leading to chronic kidney disease. There may be no history or renal disease before the diagnosis. Proteinuria and hypercholesteremia have been associated with progressive glomerular and tubular injury. The proposed mechanism is related to the observed in glomerular sclerosis and interstitial injury, such as hyperfiltration and inflammatory processes. The primary cause may be difficult to establish because advanced pathologic changes may obscure specific disease characteristics. Your renal insufficiency usually begins to develop after 10 to 20 years, followed by nephrotic syndrome and the accelerated progression to end-stage kidney failure. Symptoms patterns or symptom patterns vary depending on the underlying cause. Corticosteroids usually do not change the course of chronic glomerular disease, and dialysis or kidney transplantation ultimately may be needed. Diabetes and systemic lupus are common secondary causes of chronic glomerular injury. So here we're taking a look at chronic glomerulonephritis. The kidneys appear small, are uniformly shrunken, and have fine granular external surfaces. Your diabetic nephropathy develops from metabolic, inflammatory, and macrovascular and microvascular complications related to chronic hyperglycemia. Changes in the glomerulus are characterized by podocyte injury, progressive thickening and fibrosis of the glomerular basement membrane, expansion of the mesangial matrix, and nodular glomerular sclerosis, with proteinuria and progression to chronic renal failure. A decline in the GFR can be independent of proteinuria. Diabetic nephropathy is the most common cause of chronic kidney disease and end-stage renal failure for both type 1 and type 2 diabetics, although the incidence is declining. Lupus nephritis is an inflammatory complication of the chronic autoimmune syndrome. Systemic lupus, the renal component of the disease, may be caused by the formation of autoantibodies against double-stranded DNA and nucleosomes, with glomerular deposition of the immune complexes. Immune complexes also may be formed in situ by binding to planted antigens of the circulating autoantibodies. There is a complement activation and the cascade of inflammatory events resulting in damage to the glomerular membrane with mesangial expansion. Various glomerular lesion patterns are identifiable on biopsy, including membranous, mesangial, membranoproliferative, and diffuse proliferative glomerulonephritis. Tubular fibrosis can also be present. Symptom presentation is variable depending on lesion involvement and can include proteinuria, microscopic hematuria, edema, and other signs of nephrotic syndrome. Disease progression may be silent or may progress to end-stage kidney failure over a period of years. Treatment includes the use of immunosuppressive agents and efforts to protect the kidneys from secondary non-immune consequences of acute injury. Your nephrotic and nephritic syndromes. So what is nephrotic syndrome? Well, it is the excretion of 3.5 grams or more of protein in the urine per day. It's characteristic of glomerular injury and occurs when filtration of protein exceeds the tubular reabsorption. Your primary nephrotic syndrome includes minimal change disease, your lipoid nephrosis, your membranous glomerulonephritis, and focal segment glomerulosclerosis. Your secondary form of nephrotic syndrome occur in the systemic disease, including your diabetes, your amyloidosis, your systemic lupus, and IgA vasculitis. Your nephrotic syndrome also is associated with certain drugs, your nonsteroidal anti-inflammatory drugs, and penicillins. Infections, malignancies, and vascular disorders, familial form of nephrotic syndrome, result from genetic defects that affect the function and composition of glomerular capillary wall. Your alterations in basement membrane type 4 collagen and podocyte dysfunction. It often signifies a more serious prognosis when present as a secondary complication. Nephrotic syndrome is more common in children than in adults and is more commonly idiopathic in adults. Your nephrotic syndrome is hematuria and red blood cell casts in the urine. Proteinuria is usually less severe than a nephrotic syndrome and is related to the infiltration of inflammatory cells in the mesangium driven by antigen deposition, with damage to endothelial cells and escape of red blood cells and proteins. It occurs with infection-related glomerulonephritis, your hepatitis B and C, and acute post-streptococcal glomerulonephritis. It is rapidly progressive crescentic glomerulonephritis and lupus nephritis. So, our pathophysiology. In nephrotic syndrome, disturbances in the glomerular basement membrane, your GBM, and podocyte injury lead to a loss of electrical negative charge and increased permeability. Loss of plasma proteins, particularly albumin and some immunoglobulins, occurs across the injured glomerular filtration membrane. Loss of plasma proteins decreases plasma oncotic pressure, resulting in edema. The predominant cause of nephrotic syndrome is minimal change nephropathy, which is common in children. Your hypoalbuminemia results from urinary loss of albumin combined with a diminished synthesis of replacement albumin by the liver. Albumin is lost in the greatest quantity because of its high plasma concentration and low molecular weight. Decreased dietary intake of protein from anoxemia and malnutrition or accompanying liver disease may also contribute to lower levels of plasma albumin. Loss of albumin stimulates lipoprotein synthesis by the liver and hyperlipidemia and can promote progression of glomerular disease. Loss of immunoglobulins may increase susceptibility to infections. Sodium retention is common. Hypercoagulation results from alterations in coagulation factors, fibrinolysis, and platelet function. So here you have the pathophysiology of nephrotic syndrome. Your clinical manifestations. Many clinical manifestations of nephrotic and nephritic syndrome are related to loss of serum proteins and are associated with retention of sodium. They include edema, hypertension, hyperlipidemia, lipiduria, vitamin D deficiency, and hypothyroidism. Vitamin D deficiency is related to loss of serum transport proteins and decreased vitamin D activation by the kidneys. Hyperlipidemia can promote atherosclerotic disease. Hypothyroidism can result from urinary loss of thyroid-binding protein and thyroxine, but there may be no symptoms. Hypercoagulability may also lead to a thromboembolic events. So our clinical manifestations of nephrotic syndrome. Your proteinuria, your hypoalbuminemia, edema, hyperlipidemia, lipiduria, that decreased vitamin D, and hypothyroidism. So our evaluation and treatment. Nephrotic syndrome is diagnosed when the protein level in a 24-hour urine collection is greater than 3.5 grams. Serum albumin level decreases to less than 3 grams per deciliter, and concentrations of serum cholesterol, phospholipids, and triglycerides increase. Fat bodies may be present in the urine. Nephrotic syndrome is commonly treated by consuming a moderate protein-restricted, low-fat, and salt-restricted diet. Your diuretics are used to control hypertension and eliminate fluid. Care must be taken to observe for hypovolemia and hypokalemia, or potassium toxicity in the presence of renal insufficiency. Spironolactone may be combined with loop diuretics to suppress aldosterone activity to conserve potassium. Your heparinoids are used for prophylactic anticoagulation. Glucocorticoids are used to control immune-mediated disease, or may be combined with immunosuppressive drugs. Your angiotensin-converting enzyme inhibitors or angiotensin receptor blockers lower urine protein excretion and control blood pressure, so that the use of ACE and ARBs The evaluation and treatment of nephritic syndrome are similar to those described for nephrotic syndrome. The course of glomerulonephritis is usually more severe with nephritic syndrome. High-dose corticosteroids and cyclophosphamide represent the standard therapy for rapidly progressive crescentic glomerulonephritis. The addition of plasma exchange may also be helpful. Acute kidney injury. The classification of a kidney dysfunction. Kidney injury may be acute and rapidly progressive within hours. The process may be reversible. Kidney injury also can be chronic, progressing to end-stage kidney failure over a period of months or years. The terms renal insufficiency, renal failure, uremia, and azotemia are associated with decreasing renal function but are not specific in relation to cause of kidney disease. Often they are used synonymously, although with some distinctions. Generally, renal insufficiency refers to a decline in renal function to about 25% of the normal GFR. Levels of serum creatinine and urea are mildly elevated. The term acute kidney injury is preferred to the term acute renal failure because it captures the diverse nature of the syndrome, ranging from minimal or subtle changes in renal function to complete renal failure requiring renal replacement therapy. Renal failure refers to a significant loss of renal function when less than 10% of renal function remains. This is termed end-stage renal disease. Specific criteria for acute renal dysfunction are discussed in this next section. Uremia, or uremic syndrome, is a syndrome of renal failure and includes elevated blood urea and creatinine levels, accompanied by fatigue, anoxuria, nausea, vomiting, pruritus, and neurological changes. Uremia represents numerous consequences related to renal failure, including retention of toxic waste, deficiency states, electrolyte disorders, and immune activation, promoting a pro-inflammatory state. Azotemia is characterized by increased serum urea levels and frequently increased creatinine levels. Renal insufficiency or renal failure causes azotemia. Both azotemia and uremia indicate an accumulation of nitrogenous waste product in the blood, a common characteristic that explains the overlap in definitions of terms. So, acute kidney injury, AKI, affects about 5% of hospitalized individuals, with a higher percentage in intensive care units, and has a mortality of 50 to 80%. AKI is a sudden decline in kidney function with decrease in glomerular filtration and urine output, with an accumulation of nitrogenous waste products in the blood as demonstrated by the elevation in plasma creatinine and blood urea nitrogen levels. Staging criteria has been developed by the Kidney Disease Improved Global Outcome Working Group to guide the diagnosis of acute kidney injury. So what's the pathophysiology? AKI commonly results from extracellular volume depletion, decreased renal blood flow, or toxic inflammatory injury to kidney cells that result in alterations in renal function and may be minimal or severe. Even small changes in renal function may be associated with significant morbidity and mortality. The etiologies of AKI can be described using three categories of injury: renal hypoperfusion, disorders involving the renal parenchyma and interstitial tissue, and disorders associated with acute urinary tract obstruction. Most types of AKI are reversible if diagnosed and treated early. So we have the prerenal, the intrarenal, and the postrenal. Your prerenal acute kidney injury is the most common cause of AKI and results from inadequate kidney perfusion. Poor perfusion can be caused by hypotension, hypovolemia associated with hemorrhage, or fluid loss, such as burns, Sepsis, inadequate cardiac output from myocardial infarcts, multiple organ dysfunction, renal vasoconstriction from the use of non-steroidal anti-inflammatory drugs, or radiocontrast agents. So renal artery stenosis or kidney edema that results in arterial blood flow. During the early phases of hypoperfusion, protective autoregulatory mechanisms maintain our GFR at a relatively constant level through afferent arteriolar dilation and efferent arteriolar vasoconstriction, mediated by the angiotensin II. Tubuloglomerular feedback mechanisms also maintain GFR and distal tubular nephron flow. The GFR ultimately declines because of the decrease in filtration pressure. Sepsis, or septic shock, and cardiogenic shock following cardiac surgery are the most common causes of AKI in the critical care units. AKI may occur during chronic kidney failure if a sudden stress is imposed on early marginally functioning kidneys, hastening the progression to end-stage kidney disease. Failure to restore blood volume or blood pressure and oxygen delivery can cause cell injury and acute tubular necrosis and apoptosis or acute interstitial necrosis, a more severe form of AKI. Your intrarenal or intrinsic acute kidney injury can result from ischemic acute tubular necrosis, nephrotoxic, ATN, exposure to radiocontrast media or antibiotics, your acute glomerulonephritis or vascular disease from malignant hypertension, disseminating intravascular coagulation and renal vasculitis, or an allograft rejection, or interstitial disease from drug allergy, infection, or tumor growth. That acute tubular necrosis caused by ischemia is the most common cause of intrarenal AKI. It occurs most often after surgery and severe sepsis, but also is associated with obstetric complications and severe trauma, including severe burns. A combination of events and predisposing factors leads to the greatest risk for acute renal failure. The term acute tubular necrosis and acute kidney injury are sometimes used interchangeably, but the conditions are not the same because acute kidney injury can occur without ATN. ATN is generally described as a post-ischemic or nephrotoxic, or it can be a combination of both. Post-ischemic ATN involves persistent hypotension, hypoperfusion, and hypoxemia, producing ischemia and reduced levels of ATP and generating toxic oxygen-free radicals with loss of antioxidant protection that causes cell swelling, injury, and necrosis. Activation of inflammatory cells, those neutrophils, macrophages, and lymphocytes, and complement and release of inflammatory cytokines contribute to the tubular injury. Transport of sodium and other molecules is disrupted with damage primarily to the proximal tubular epithelium and shredding of the brush border with the appearance of tubular granular casts in the urine. Ischemic necrosis tends to be patchy and may be distributed along any part of the nephron tubules. Injury is the most severe in the outer medulla, with scattered necrosis in the cortex and loss of cells along the tubular epithelium. Severe disease of the glomeruli or renal microvascular disorders also can cause intrinsic kidney injury. Oliguria is common with intrarenal AKI, but anuria is rare. Creatinine values in septic renal injury may not reflect renal injury because sepsis decreases production of creatinine without major alterations in body weight, hematocrit level, or amount of extracellular fluid. Creatinine levels usually increases with decreased renal blood flow and decreased GFR. However, in sepsis-induced AKI, Creatinine values can remain within normal range and may be related to alterations in intrarenal microcirculatory blood flow that are different from the kidney ischemia that develops related to systemic hypotension and hypoperfusion of non-septic AKI. Sepsis-related tubular injury can occur in the absence of hypoperfusion and may be related to inflammation and changes in microcirculation and mitochondrial function. Nephrotoxic ATN can be produced by radiocontrast media and numerous antibiotics, particularly aminoglycosides. Because the drugs accumulate in the renal cortex, other substances such as carbon tetrachloride, heavy metals, mercury and arsenic, methoxyfluorine, anesthesia, or bacterial toxins may promote renal failure. Endogenous substances toxic to renal tubules are excessive myoglobin, the oxygen transporting substance in muscles, and hemoglobin. Dehydration, advanced age, concurrent renal insufficiency, and diabetes mellitus tend to enhance nephrotoxicity. Necrosis and tubular cell apoptosis caused by nephrotoxins are usually uniform and limited to the proximal tubules. The high surface area of the brush border, the microphyllae, of the proximal tubular cells and the reabsorption properties of epithelial cells makes them more vulnerable to toxic injury. Post-renal acute kidney injury is rare and usually occurs with urinary tract obstruction that affects the kidneys bilaterally. The obstruction causes an increase in intraluminal pressure upstream from the site of obstruction with a gradual decrease in GFR. A pattern of several hours of anuria with flank pain, followed by polyuria, is a characteristic finding. This type of AKI can occur after diagnostic catheterization of the ureters, a procedure that may cause edema with obstruction of the tubular lumen. Oliguria can occur in AKI, and 3 mechanisms have been proposed to account for the decrease in urine. All 3 mechanisms probably contribute to oliguria in varying combinations of degrees throughout the course of the disease. And the mechanisms are as follows. Your prerenal, a decreased renal blood flow, means hypoperfusion, means a decrease in GFR, which means there's an increase in proximal tubule sodium and water reabsorption, an increase in aldosterone ADH secretion, which leads to an increase in distal tubule sodium and water reabsorption, hence oliguria. In the intrarenal aspect, we have the renal tubular injury, your necrosis or apoptosis, which creates a cast formation. That cast formation releases the release of inflammatory mediators and vascular endothelial cell injury, which leads to renal vasoconstriction, which then leads to a persistent medullary hypoxemia, which further causes renal tubular injury. That cast formation also increases intratubular obstruction, which increases intratubular pressure, which is a tubular back leak, which decreases our GFR, leading us to oliguria. And lastly, the postrenal section. The bilateral obstruction of urine flow means there's an increase in intraluminal pressure. That increased pressure then release of inflammatory mediators and vascular endothelial cell injury, which again can cause that renal vasoconstriction, which is persistent to the medullary hypoxia, which causes the renal tubular injury, but also causes cellular interstitial edema. Again, we have that decreased glomerular filtration pressure, leading us to oliguria. So, are alterations in renal blood flow in response to ischemia? Blood flow is directed to the highly metabolic renal medulla. With continuing severe ischemia, tubular sodium chloride reabsorption fails, and tubuloglomerular feedback at the macula densa activates the renin-angiotensin-aldosterone system. There's an increased afferent vasoconstriction and decrease in GFR. Damaged endothelium and leukocyte activation activate coagulation and further impede microcirculatory blood flow, contributing to ischemia, reperfusion injury, and decreased GFR. Decreased GFR can be life-saving. Otherwise, GFR would not change and death could result from continuing fluid loss during concurrent hypovolemia and hypotension. Autoregulation of blood flow is impaired, contributing to decreased GFR. That leads us to our tubular obstruction. Necrosis of the tubules causes sloughing of cells, cast formation, and ischemic edema that results in tubular obstruction, which in turn causes a retrograde increase in pressure and reduction in GFR. Renal failure can occur within 24 hours. And then the tubular back leak. Glomerular filtration remains normal, but tubular reabsorption or leak of filtrate is accelerated as results of permeability caused by ischemia and increased tubular presence or pressure from obstruction. That obstruction and back leak probably occurs concurrently. So what are our clinical manifestations? The clinical progression of acute kidney injury, particularly acute tubular necrosis, occurs in phases, initiating phase, extension phase, maintenance phase, and the recovery phase. The initiation phase is the phase of reduced perfusion or toxicity, in which renal injury is evolving. It usually lasts 24 to 36 hours. Prevention of injury is possible during this phase. During the extension phase, and with progressive ischemia, there is infiltration of inflammatory cells, mostly neutrophils, the release of cytokines, inflammation, and cell injury contributing to tubular obstruction and back leak. The maintenance or oliguric phase is the period of established renal injury and dysfunction after the initiating event has been resolved and may last from weeks to months. Urine output is lowest during this phase, and serum creatinine, blood urea nitrogen, and serum potassium levels increase. Metabolic acidosis develops, and there is salt and water overload. The recovery phase is the interval with renal injury is repaired and normal renal function is reestablished. GFR returns towards normal, but the regenerating tubules cannot concentrate the filtrate. Diuresis is common during this phase, with a decline in serum creatinine and urea levels, and an increase in creatinine clearance. Polyuria can result in excessive loss of sodium, potassium, and water. Fluid and electrolyte balance requires careful maintenance. Oliguria begins within 1 day after the hypotensive event and lasts for 1 to 3 weeks, but it may regress in several hours or extend for several weeks, depending on the duration of the ischemia or the severity of the toxic injury and the initiation of treatment. Anuria, urine output less than 50 ml a day, is uncommon in ATN, and 10 to 20% of cases have non-oliguric failure. Anuria involves both kidneys and suggests bilateral renal artery occlusion, obstructive uropathy, or acute cortical necrosis. Non-oliguric renal failure usually represents less severe injury and is associated with toxin exposure or drug toxicity. The renal tubules have impaired reabsorption and concentration and dilution function. The urine output may be greater than 2 liters a day, but the blood urine nitrogen, the BUN, and plasma creatinine concentrations continue to increase. Other early manifestations depends on the underlying cause of the renal failure. Individuals who have experienced trauma or surgery, or people in a catabolic state, may have more rapid elevations in BUN level. They are prone to hyperkalemia and metabolic acidosis. Renal phosphate excretion is decreased, causing hyperphosphatemia. Fluid retention may cause edema. Symptoms of congestive heart failure develop in persons with a cardiac disease. Nausea, vomiting, and fatigue accompanying uremia and electrolyte imbalances. Wound healing is delayed, and the risk of infection, particularly your pneumonia, is greater. Your non-oliguric renal failure generally has a better prognosis because of fewer complications and regeneration of the tubular epithelium. Individuals with oliguria may require maintenance dialysis to attenuate symptoms of renal failure. As renal function improves during the recovery phase, increase in urine volume, that diuresis, is progressive. During the early diuretic phase, the tubules are still recovering secretory and reabsorption function. Sodium and potassium are lost in the urine, and the risk for hypokalemia is greater. Volume depletion may ensue, with fluid loss of 3 to 4 liters a day. Fluid and electrolyte balance must be carefully monitored, and excessive urinary loss is replaced. Return to normal status may take 3 to 12 months. AKI is a risk factor for progression to end-stage kidney disease and other complications, such as cardiovascular events and strokes. So, what is our evaluation and treatment? The diagnosis of AKI is related to the cause of the disease. The history can help distinguish the different etiologies of AKI, whether its pre-renal causes are associated with the history of blood volume depletion or other causes of poor kidney perfusion that shock, heart failure, renal artery thrombi. Intrinsic causes include exposure to nephrotoxins and infection. Your post-renal causes are associated with obstruction, uropathies, that enlarged prostate, or kidney stones. The diagnostic challenge is to differentiate pre-renal, acute renal injury from acute tubular necrosis. Urine composition may provide helpful diagnostic clues to change the tubular function. So, there is a diagnostic index for pre-renal versus ATN. So for urine volume, both are less than 400 ml in your urine output. However, urine specificity for a pre-renal patient is 1.016 to 1.020. Your urine osmolality is greater than 500 MOSM. Urine sodium is usually less than 10 MEq per liter. Your BUN plasma is greater than a 15 to 1 ratio. Your iron sodium, your Fe sodium, is less than 1%, also seen in acute glomerulonephritis. And your urine sediment usually has no cells, maybe some Hyaline tests. For ATN, again, the urine volume is also less than 400. However, the urine specificity is 1.010 to 1.012, so it's a much smaller narrow window. Your urine osmolality is less than 300. Again, the pre-renal was greater than 500. Your urine sodium is usually greater than 30 MEq per liter. Again, pre-renal was less than 10. Your BUN and creatinine, or your BUN plasma, that ratio is very small. It's less than 15 to 1 creatinine. And again, in pre-renal, it was greater than 15 to 1. Your Fe sodium is greater than 1%, but it's also seen in urinary tract obstruction and renal parenchymal disease. So that FeNA isn't really the big differentiating factor. Your urine sediment, however, has brown granular casts and epithelial cells. So there are big differences. Your FeNA is actually your fractional excretion of sodium. So there are those differences listed. The ratio of BUN to plasma creatinine concentration and fractional excretion of sodium are helpful diagnostic indicators because the tests reflect renal tubular reabsorption ability. In pre-renal AKI, tubular function is maintained and salt water and urea are reabsorbed. With ATN, reabsorption and urinary concentration abilities are compromised. Other causes of renal failure also may exhibit Similar clinical findings. Cystatin C, a serum protein constantly produced by nucleated cells, is freely filtered by the glomerulus, and its concentration can serve as a measure of GFR and may be useful for detecting early changes in glomerular filtration rate. Serial measurements of plasma creatinine concentration provide an index of renal function during the recovery phase. However, changes in serum creatinine levels occur only if more than 50% of glomerular filtration is lost and are often delayed by more than 24 hours. The diagnostic delays make the implementation of early therapy very difficult, contributing to disease progression and mortality. Advances are being made in the use of biomarkers that allow assessment of kidney injury and estimates of renal function. Prevention of AKI and maintenance of renal perfusion involve maintenance of fluid volume before and after surgery, or diagnostic procedures, and when nephrotoxic drugs or contrast agents are in use. There is no specific treatment for acute kidney injury, and it requires individualized therapy and monitoring. The primary goal of therapy once AKI has occurred is to maintain the individual's life until renal function has recovered. Management principles directly related to physiologic alterations generally include correcting fluid and electrolyte disturbances, managing blood pressure, preventing and treating infection, maintaining nutrition, and remembering that certain drugs or their metabolites are not excreted and can be toxic. Fluid and electrolyte replacement must be carefully calculated with consideration of urine loss, insensible loss, and production of endogenous water by oxidation. Overhydration of individuals dilutes their plasma sodium concentration and can precipitate pulmonary, cerebral, myocardial, and liver edema, as well as other complications. Metabolic acidosis is treated with serum bicarbonate concentration less than 22 MEq per liter. Hyperkalemia can be managed by restricting dietary sources of potassium, using non-potassium sparing diuretics, or using cation-ion exchange resins, which may be administered orally or rectally. These resins exchange potassium for another cation, such as sodium, in the bowel, and the potassium is then excreted attached to the resin. With severe hyperkalemia, dialysis may be required, or potassium can be driven back temporarily into the cells by administering glucose and insulin by infusing sodium bicarbonate or albuterol. Glucose metabolism causes potassium to move to the intracellular fluid, and insulin infusion, therefore, may be effective in shifting potassium from the extracellular to the intracellular space, along with the transport of glucose within 30 minutes. Using sodium bicarbonate to cause alkemia to shift or also shifts potassium into cells in exchange for hydrogen ions, but requires consideration of hypervolemia. Careful monitoring of electrocardiogram for peaking T waves is essential for individuals with hyperkalemia. Intravenous infusion of calcium is the most rapid method of treating cardiac effects of hyperkalemia. Calcium decreases the threshold potential and reduces the membrane excitability caused by hyperkalemia. Calcium should only be used in emergencies. However, because hypercalcemia also may cause cardiac arrest. Azotemia is generally controlled and nutrition maintained with a low protein, high carbohydrate diet. Essential amino acid replacement can be given orally or parenterally. Adequate carbohydrate intake slows protein catabolism and helps prevent release of potassiums from cellular breakdown. Because sepsis is a common, serious, and potentially fatal complication of renal disease, observation for signs of infection and early treatment with antibiotics are necessary. Drug dosage levels may require adjustment if they are metabolized or excreted by the kidneys, as recovery can take up to a year. Continuous renal replacement therapy, that's CRRT, hemodialysis, is indicated for uncontrollable hyperkalemia or acidosis, or severe fluid overload. CRRT is particularly promising in critically ill people with multiple organ dysfunction or sepsis. The timing and optimal dose-response relationship for CRRT are individually determined. So what is our chronic kidney disease? Chronic kidney disease is the progressive loss of renal function associated with systemic disease such as hypertension, diabetes, systemic lupus, erythematosus, or intrinsic kidney disease. I'm not sure why hypertension was listed twice, but it also, or including acute kidney injury, chronic glomerulonephritis, chronic pyelonephritis, obstructive uropathies, or vascular disorders. The KDIGO guidelines define the stage CKD using estimates of GFR and albuminuria. Chronic kidney disease is the preferred terminology and is reference to declining GFR. The terms renal insufficiency and chronic renal failure are often still used to describe declining renal function, but they do not have the specificity of the stages recommended by KDIGO. CKD decreases filtration and tubular function, with consequences manifested throughout all organ systems. So there are several stages, up to 5. So in CKD stage 1, kidney damage normal or an increased GFR, if the GFR is greater than 90. Stage 2, kidney damage is mild with a decreased GFR, 60 to 89, a moderate GFR. In stage 3 is 30 to 59. Then in severe cases, there's severe decrease in GFR, 15 to 29, and end-stage kidney disease, or stage 5, where the GFR is less than 15. There are associated albuminuria, the progression, and symptoms. So I'll let you read those as we click through here. So what is the pathophysiology? The kidneys have a remarkable ability to adapt to loss of nephron mass. Symptomatic changes result from increased levels of creatinine, urea, and potassium. Alterations in salt and water balance usually do not become apparent until renal function declines to less than 25% of normal, when adaptive renal reserves have been exhausted. Different theories have been proposed to account for the adaptation to loss of renal function. The intact nephron hypothesis proposes that loss of nephron mass with progressive kidney damage causes the surviving nephron to sustain normal kidney function. These nephrons are capable of a compensatory hypertrophy and expansion of hyperfunction in their rates of filtration, reabsorption, and secretion, and can maintain adaptive changes in solute and water regulation in the presence of overall declining GFR. Although the urine of an individual with chronic kidney failure may contain abnormal amounts of protein and red and white blood cells or casts, the major end product of excretion are similar to those of normally functioning kidneys until the advanced stages of renal failure, when there is a significant reduction of functioning nephrons. With severe or repeated injury, epithelial cells have an impaired proliferative response, resulting in interstitial capillary loss and fibroblast proliferation. The progressive process of glomulosclerosis and tubulointerstitial fibrosis contributes to end-stage kidney disease. The particular location of kidney damage also can influence loss of kidney function. For example, tubular interstitial disease damage primarily the tubular or medullary parts of the nephron, producing problems such as renal tubular acidosis, salt wasting, and difficulty diluting or concentrating the urine. When the damage is primarily vascular or glomerular, proteinuria, hematuria, and nephrotic syndrome are more prominent. A summary of factors involved in the progression of chronic kidney disease is outlined in Table 3913. So there is proteinuria, creatinine and urine clearance, your sodium and water balance, phosphate and calcium balance, hematocrit, potassium balance, acid-base balance, and dyslipidemia. We're going to jump right over this though. Here is a picture of the mechanism related to the progression of chronic kidney disease. I'll leave that up for just a moment. The factors that contribute to the pathogenesis of CKD are complex. And I'll go up a little bit, so can't. I'll leave it up as long as I can. The factors that contribute to the pathogenesis of CKD are complex and involve the interactions of many cells, cytokines, and structural alterations. Two factors that have consistently been recognized to advance renal disease are proteinuria and angiotensin II activity. Glomerular hyperinfiltration and increased glomerular capillary permeability lead to proteinuria. Proteinuria contributes to tubulointerstitial injury by accumulating in the interstitial space and activating the complement proteins and other mediators and cells, such as macrophages, that promote inflammation and progressive fibrosis. Angiotensin II activity is elevated with progressive nephron injury. Angiotensin II promotes glomerular hypertension and hyperfiltration caused by efferent arteriolar vasoconstriction and also promotes systemic hypertension. The chronically high intraglomerular pressure increases glomerular capillary permeability, contributing to proteinuria. Angiotensin II also may promote the activity of the inflammatory cells and growth factor that participate in the tubulointerstitial fibrosis and scarring. So what kind of clinical manifestations do we see with CKD? The clinical manifestations of CKD are often described using the terms azotemia and uremia. Azotemia is manifested by increasing levels of serum urea, serum creatinine, and other nitrogenous compounds related to the decreasing kidney function. Uremia is the pro-inflammatory state with many systemic effects known as uremic syndrome and is associated with the accumulation of the urea and other nitrogenous compounds and toxins. Sources of toxins include the accumulation of end products of protein metabolism, alterations in fluid and electrolytes, metabolic acidosis, intestinal absorption of toxins produced by gut bacteria, and results of altered renal hormone synthesis, the anemia, hyperphosphatemia, and hypocalcemia. Generally, the symptoms include hypertension, anorexia, nausea, vomiting, diarrhea, or constipation, malnutrition and weight loss, pruritus, edema, anemia, and neurologic cardiovascular disease, and skeletal changes. So the many systemic manifestations associated with uremia are on this table. So just look at the skeletal system, for instance, here. The cardiopulmonary system, the cardiovascular system, the neurologic system, our endocrine system, hematologic system, gastrointestinal, integumentary, our immune, and finally our reproductive. So, if we're looking at the human body, common signs and symptoms of CKD, here you can kind of take a look at a picture of all these signs and symptoms as well. That leads us to the creatinine, urea clearance, and cystatin C. Creatinine is constantly released from muscle and excreted primarily by the glomerular filtration. As the GFR declines in CKD, the serum creatinine, your SCR level, increases by reciprocal amount to maintain a constant rate of excretion. Because no significant tubular adjustment occurs for creatinine, or tubular secretion, the SCR levels continue to increase as the GFR decreases. Therefore, measures of plasma creatinine can serve as an index of changing glomerular function. However, SCR, as an estimate for GFR, is limited when there is reduced muscle mass or fluid overload. Equations including cystatin C or the combined with serum creatinine provide a better index. The clearance of urea follows a pattern similar to that of creatinine, but urea is filtered as well as reabsorbed and varies with the state of hydration. It is not a good index of GFR. However, as the GFR decreases, plasma urea concentration also increases. So we've got that inverse effect of glomerular filtration rate and our plasma creatinine. Our fluid and electrolyte balance. Fluid and electrolytes and acid-base balance are significantly disturbed with chronic kidney disease. We're going to take a peek briefly at our electrolyte and acid balance alterations on this table. So here is our serum and water balance, phosphate and calcium, potassium, and acid base. So I'll let you read that. So levels of sodium must be regulated within narrow limits because sodium is a major extracellular solute. In CKD, sodium and water balance is maintained very closely to normal until the development of stage 5 end-stage kidney disease. This occurs because the increased fractional excretion of sodium, particularly in the distal nephron, in relation to the decreasing GFR. Hormones including aldosterone, prostaglandins, and natriuretic peptide also modulate sodium excretion, and their levels are elevated with progressive renal failure. Individual variation in the underlying pathology of CKD must be considered in the management of sodium uptake or intake or its restriction. Sodium wasting may be present with tubulointerstitial causes of CKD. There may also be extrarenal losses of sodium from vomiting, diarrhea, or fever. Sodium retention is more likely in ESKD, particularly in the presence of nephrotic syndrome or heart failure. Sodium retention contributes to the hypertension, edema, heart failure, and mortality. Interdialytic water intake can cause volume overload and dilutional hyponatremia during dialysis. Management of salt and water balance requires individual assessment, and both hyponatremia and hypernatremia require management. The regulation of water balance and osmolality is normally achieved by urinary concentration mediated by antidiuretic hormone, that ADH. As GFR is reduced, ability to concentrate and dilute the urine diminishes. In early stages of renal failure, this may be caused by osmotic diuresis, produced by increased fractional excretion of solutes by the remaining nephrons or by a decreased tubular response to the ADH. Individual nephrons can maintain water balance until severe renal failure occurs and that GFR declines to 15 to 20% of normal, with extensive loss of nephron and tubular function. At this stage, the urinary concentration becomes fixed and approaches that of the plasma of 285 MOSM per liter, with a specific gravity of about 1.010. So urinary excretion of potassium is related primarily to distal tubular secretion mediated by aldosterone and sodium potassium adenosine triphosphate. In renal failure, there is increased tubular secretion that provides effective regulation until the onset of oliguria. With hyperkalemia, Larger amounts of potassium can be eliminated through the bowel. Although non-oliguric patients can maintain potassium excretion with normal dietary intake, they are more prone to develop hyperkalemia with increased loading, the use of salt substitutes. Use of potassium-sparing diuretics such as spironolactone or aldactone, volume depletion, acute infection, severe acidosis, or marked hyperglycemia also may precipitate elevated levels of serum potassium. With progression of disease to end-stage renal failure, total body potassium can increase to life-threatening levels and must be controlled by dietary restriction, loop diuretics, cation exchange resins, and dialysis. Hyperkalemia also can be a side effect of ACE inhibitors or receptor blockers, often used to prevent diabetic nephropathy. The new drug Pediaromor Sorbatex calcium is FDA approved. Sodium zirconium cyclosilate traps potassium in the colon. Is currently investigational. So the trade name to that is actually called Lokelma, and it currently in 2024 extremely expensive. 3 doses of Lokelma cost you about $800 at this time. Both are effective in managing hyperkalemia. Severe acute hyperkalemia is treated with intravenous 10% calcium gluconate or 10% calcium chloride, IV dextrose and insulin, and nebulized or intravenous salbutamol, a sympathetic beta-2 agonist, which promotes the sodium-potassium ATP pace pump and intracellular movement of potassium. Renal replacement therapy may be required. Support of renal function using hemodialysis or peritoneal dialysis. The intake of normal diet produces 50 to 100 MEq of hydrogen per day. These ions are secreted from the renal tubules and excreted in the urine, combined with phosphate and ammonia buffers. Metabolic acidosis develops when GFR decreases to less than 20 to 25% of normal. The causes of acidosis are primarily related to the decreased hydrogen ion elimination and decreased bicarbonate reabsorption. With end-stage renal failure, metabolic acidosis may be severe enough to require alkali therapy and dialysis. Bicarbonate levels should be maintained at about 22 MEq per liter. So, what does that mean for our calcium, phosphate, and bone? Bone and skeletal changes develop with alterations in calcium and phosphate metabolism. These changes begin when the GFR decreases to less than 25% or less. Hypocalcemia is accelerated by impaired renal synthesis of that 1-25-dihydroxyvitamin D, calcitriol, with decreased intestinal absorption of calcium. Renal phosphate excretion also decreases, and the increased serum phosphate binds calcium, further contributing to the hypocalcemia. Acidosis also contributes to the negative calcium balance. Decreased serum calcium levels stimulates parathyroid hormone secretion with mobilization of calcium from bone and may cause calcium levels to approach normal. The combined effect of secondary hyperparathyroidism and vitamin D deficiency can result in renal osteodystrophies, your osteomalacia, and osteitis fibrosa, with increased risk for fractures. And vascular calcification, including coronary artery calcification. Fractional excretion of magnesium increases as CKD progresses and also may contribute to a cardiovascular complication. So what does that mean for our proteins, our carbohydrates, and our fat metabolism? Well, our proteins, your carbohydrates, and fat metabolism are altered in CKD. Proteinuria and a catabolic state contribute to a negative nitrogen balance. Levels of serum proteins diminish, including albumin, complement, and transferrin, and there is a loss of muscle mass. Proteinuria may independently cause renal damage by promoting tubular inflammation and fibrosis. The amount of proteinuria is also related to the extent of renal injury and predicts disease progression. Monitoring of proteinuria using the albumin to creatinine ratio can assist in staging chronic kidney disease. Hyperinsulinemia and glucose intolerance related to insulin resistance are common and may be related to alterations in adipokines that interfere with insulin action and oxidative stress that contributes to renal tubular and vascular injury in both non-diabetic and diabetic CKD. Hyperparathyroidism also decreases insulin sensitivity and impairs glucose tolerance. High levels of adiponectin have been associated with increased mortality in progressive CKD. Dyslipidemia is common among individuals with CKD. There is a high ratio of low-density lipoprotein to high-density lipoprotein. High levels of triglycerides and accumulation of LDL particles with accelerated atherosclerosis and vascular calcification. Uremia causes a deficiency in lipoprotein lipase and decreased hepatic triglyceride lipase. Decreased lipolytic activity results in a reduction in HDL level. CKD also impairs the metabolism and protective effects of HDL. Apolipoprotein B concentrations also is elevated, thereby accelerating atherogenesis. Cardiovascular. Your cardiovascular disease is a major cause of morbidity and mortality in CKD. Pro-inflammatory mediators, oxidative stress, and altered vitamin D metabolism and metabolic derangements are significant contributors. Declining erythropoietin production causes anemia, which causes oxygen delivery to the myocardium. Elevated renin level stimulates the secretion of aldosterone, increasing sodium and water reabsorption. Hypertension is a result of excess sodium and fluid volume. Dyslipidemia occurs early in CKD. Arterial wall thickness increases with decreased elastic fibers and increased extracellular matrix. Atheromatous plaque and arterial calcification contribute to the loss of vessel elasticity and obstruction and are accelerated by oxidative stress of CKD. Macrovascular disease is responsible for increased risk for ischemic heart disease, left ventricular hypertrophy, congestive heart failure, stroke, and peripheral vascular disease in individuals with uremia. Endothelial cell dysfunction and calcium deposits lead to a loss of vessel elasticity and vascular calcification. The resulting vascular disease increases the risk for ischemic heart disease, left ventricular hypertrophy, congestive heart failure, stroke, peripheral vascular disease in individuals with uremia. Pericarditis can develop from inflammation caused by the presence of uremic toxins. The accumulation of fluid in the pericardial space can compromise ventricular filling and cardiac output. Our pulmonary or respiratory system. Pulmonary edema results from fluid overload and congestive heart failure. Dyspnea is a common end-stage kidney disease. Metabolic acidosis can cause Kussmaul respirations. Our hematologic system alterations include normochromic nomocytic anemia, impaired platelet function, and hypercoagulability. The inadequate production of erythropoietin decreases red blood cell production and is the most significant factor in contributing to anemia. Chronic inflammation, iron deficiency, and decreased half-life of erythrocytes are also contributing factors. Anemia contributes to the decreased tissue oxygenation and to the progression of the kidney disease. Low levels of hemoglobin and symptoms of anemia, such as lethargy, weakness, and dizziness, are common findings. Treatment of anemia includes erythropoiesis stimulating agents and intravenous iron. The safety and cost benefit of new drug classes to stimulate erythropoiesis are under investigation. Disorders of hemostasis in CKD are primarily related to defective platelet aggregation, impaired adhesion of platelets to the vascular endothelium, and alterations in coagulation factor and the fibrinolytic pathway. The consequence is either 1. An increased bleeding tendency, more common with later stages of CKD, manifested by bruising, epistaxis, and other mucosal bleeding, GI bleeding, and cerebrovascular hemorrhage, or 2. Excessive formation of thrombi, your DVT thrombosis, pulmonary embolism, and cardiovascular events, which is more common in the earlier stages of CKD. Our immune system. Immune system dysregulation with immune suppression, deficient response to vaccination, intestinal barrier dysfunction, and dysbiosis, and increased risk for infection develop as CKD. Chemotaxis, phagocytosis, antibody production, and cell-mediated immune responses are suppressed. Malnutrition, metabolic acidosis, hyperglycemia, or effects of hemodialysis may amplify immunosuppression. The neurologic system. Neurologic symptoms are common and progressive with CKD and are related to dysfunction of lower motor and sensory neurons associated with uremic toxicity, chronic hyperkalemic depolarization, and anemia. Neuromuscular irritation can cause hiccups, muscle cramps, and muscle twitching. In advanced stages of renal failure, symptoms may progress to seizures and coma. Peripheral neuropathies also develop with impaired sensation, decreased tendon reflexes, muscle weakness, and muscle atrophy, most commonly in the lower extremities. Symptoms may include headache, drowsiness, pain, sleep disorders, impaired concentration, memory loss, and impaired judgment, uremic encephalopathy. Diabetic neuropathy can occur concurrently. Renal replacement therapy or kidney transplant improves symptoms. So your gastrointestinal system, your GI complications are common in individuals with CKD. Uremic gastroenteritis can cause bleeding ulcers and significant blood loss. Nonspecific symptoms include anorexia, nausea, vomiting, constipation, or diarrhea. Uremic fetor is a form of bad breath caused by the breakdown of urea by salivary enzymes. Malnutrition is common. Your endocrine system and reproductive systems. Endocrine and reproductive alterations develop with the progression of CKD. Males and females have decrease in levels of circulating sex steroid hormones. Males often experience a reduction in testosterone levels and may be impotent. Oligospermia and germinal cells dysplasia can result in infertility. Females have reduced estrogen levels, amenorrhea, and difficulty with conception and maintaining a pregnancy to term. A decrease in libido occurs in both genders. Renal replacement therapy and kidney transplantation improve sexual dysfunction. There is no guideline related to sex hormone replacement therapy and end-stage kidney disease. Insulin resistance is common in uremia. Low-grade systemic inflammation, oxidative stress, vitamin D deficiency, and anemia may be contributing factors with increased risk for cardiovascular disease. As CKD progresses and the ability of the kidney to clear adiponectin and leptin and degrade insulin is reduced, the half-life of insulin is prolonged. Individuals with diabetes, mellitus, and CKD need to carefully manage their insulin dosage. Low-protein diets and renal replacement therapy improve insulin sensitivity. CKD also causes alterations in thyroid hormone metabolism and low thyroid hormone levels and is known as non-thyroidal illness syndrome, and increased risk for cardiovascular disease. Low-grade inflammation and oxidative stress may be a contributing factor. Uremia and reduced conversion of triiodothyronine or T3 and tetraiodothyronine T4 thyroxine. Your skin. Integumentary system or skin changes are associated with complications that develop with CKD. Anemia can cause pallor and bleeding into the skin and results in hematomas, and ecchymosis. Retained urochromes manifest as a sallow skin color. Hyperparathyroidism and uremic skin residues related to calcium and phosphorus levels and alterations in opioid receptors are associated with irritation and pruritus. With scratching, excoriation, increased risk for infection, impaired sleep, and depression. Your, your evaluation and treatment, therefore, early screening and evaluation for CKD are based on risk factors, the history, presenting signs and symptoms, and your diagnostic testing. Prediction equations incorporating serum creatinine and cystatin C, or both, are used for estimating GFR. Markers of kidney damage include urine protein, particularly albumin, and an examination of urine sediment. There's new biomarkers for predicting progression of CKD, and then they're being evaluated. Renal biopsies confirm any kind of diagnosis in that sense. Management involves dietary control, including the management of protein intake, vitamin D supplementation, sodium and fluid maintenance, potassium restriction, adequate caloric intake, and management of dyslipidemias, erythropoietin-stimulating agents, and adjuvant iron therapy is needed. Hyperphosphatemia is managed with a low phosphorus diet, phosphate binders, vitamin D replacement, calcimimetics, and parathyroidectomy, while maintaining normal serum calcium levels. Your end-stage kidney disease related to diabetic nephropathy can be significantly reduced with the control of hyperglycemia, hypertension, hyperlipidemia, and albuminuria. Your ACE inhibitors or receptor blockers are often used to control systemic hypertension, decrease albuminuria, and provide renal protection in the presence of diabetes mellitus and mild chronic kidney injury. They are under investigation for advanced CKD. Your statins and fibrates are used to control hyperlipidemia. Your sodium glucose cotransporter 2 inhibitors are being evaluated for the nephroprotection actions and renal gluconeogenesis inhibition. End-stage kidney disease is treated with dialysis, supportive therapy, and lastly, a renal transplant when possible. That concludes our chapter here, chapter 39, our alterations of renal and urinary function. So again, we talked about UTI, glomerular disorders, acute kidney injury, and chronic kidney injury. I will see you in the next chapter. I will see you then. Bye-bye.